When someone's in cardiac arrest, we're in a race against time. Their heart is sending out its last desperate signals. And knowing how to read those signals, well, that can be the line between life and death. So let's dive right in and take a look at the ECG of a dying heart.
All right, first up, we have to talk about something called the Agonal paradox. And trust me, it's one of the most confusing things in all of resuscitation. Here's why. You hear the word agonal, and it can mean two completely opposite things. Agonal breathing, you know, those big gasping breaths, that's actually a good sign. It tells us the brainstem is still kicking. But an agonal rhythm on the heart monitor, that's a really, really bad sign. It's the heart basically shutting down. Same word, totally different meanings.
So the big question is, how does a heart even get to this point? Well, to really get it, we need to zoom in. I mean, way in, down to the microscopic level. We're going to look at the power failure that's happening inside every single heart cell.
Everything kicks off with this one word, ischemia. It's just a fancy way of saying the oxygen supply gets cut. The second that happens, it's like someone just pulled the main breaker on the heart's power grid. The cells have to scramble and switch to these tiny, weak backup generators, and they are just not enough to keep the lights on for long.
And that power failure creates this catastrophic domino effect. You see it here. Step 1, no more oxygen. That means the cells can't make ATP, which is basically their fuel. Without fuel, the tiny pumps that keep everything electrically balanced just stop working. And once those pumps fail, the heart's entire communication network just grinds to a halt.
And here's the thing. This isn't some invisible process. We can literally see the results of this power outage right on the heart monitor. That electrical signal, what we call the QRS complex, it starts to get wider and wider and wider. It's like a text message getting stretched out until you can't even read the words anymore.
Okay, so that's the why it happens. Now let's talk about the what. What do we actually see on the screen? Let's decode these final messages the heart is sending us.
So what are we looking for? These are the classic signs, the fingerprints of an agonal rhythm. First, the rate is crazy slow. We're talking less than 20 beats per minute. It's completely irregular. There are no P waves, which are the signals from the top chambers of the heart. And that QRS complex we talked about, it's just huge, wide, and frankly bizarre looking. This is truly the heart's last gasp. You know, there's a phrase in the medical literature that just nails it. It calls this rhythm the chaotic sputtering of a dying engine. And that's exactly what it is. It's not a real heartbeat. It's just random, ineffective electrical noise right before the engine goes completely silent. So, this obviously leads to the biggest question of all, right? When you see this on the monitor, is that it? Is it game over? Is this pattern always a death sentence?
And the answer is, not always, because there's a twist. There's what we call the great imitator. It's a condition that can look almost identical on the monitor, but for a totally different, and get this, potentially fixable reason. And that condition is severe hyperkalemia, which just means dangerously high potassium in the blood.
Okay, this table is super important. Just look at the differences here between a standard agonal rhythm and what we call the hyperkalemic sine wave. Yeah, they're both non-shockable rhythms. You don't use the defibrillator, but the treatment is worlds apart. For the sine wave, the key isn't just CPR and epi, it's giving calcium. And spotting that difference, that can be the thing that changes everything.
All right, so this brings us to the playbook. You're the clinician, you see this on the monitor. What's the move? What does the evidence say is the absolute best course of action?
Okay, first things first. Let's just be real for a second. The numbers here are grim. The survival rate for a patient in an agonal rhythm is less than 2%. I mean, think about that. It is one of the deadliest situations in all of medicine.
So you might be asking, why even bother then? And the answer is simple. We try because of that tiny chance. Because hidden inside that horrible statistic are the few people whose problem is something we can actually fix. The whole point of running the code is to find those people.
For any of these non-shockable rhythms, the first steps are always the same. It's all about the basics, the absolute fundamentals. We're talking high-quality CPR to be the heart's pump, giving 100% oxygen, getting an IV line in, and giving epinephrine to try and get that blood pressure up.
And here's something really important, a key update from the new guidelines. For a long time, if we couldn't get an IV, we'd go for an IO. That's a line straight into the bone. It's fast. But new research is showing that a good old-fashioned IV is actually linked to better survival. The theory is it just gets the drugs to the heart more effectively. So the new thinking is try for that IV first. So while all that's happening,
the CPR, the meds. The team leader is running through a mental checklist. We call it the H's and T's. They're asking, could this be a lack of oxygen, hypoxia? Could it be that high potassium we just talked about? Is their blood too acidic? Are they freezing cold? Each one of these is a potential clue, a possible way out.
This chart really lays out the whole strategy. You see that huge slice? That's CPR and epinephrine. That's our bread and butter. But look at those smaller slices. That's the calcium for hypotassium or maybe bicarbonate for acidosis. Those are the specific, targeted treatments that can be absolute game changers. And notice the slice for defibrillation? It's not there. You do not shock this rhythm. It's useless and can actually make things worse.
Okay, now we get to what is, without a doubt, the hardest part of any resuscitation: making the call, knowing when to stop. How do we use all this information to decide when enough is enough?
One of the biggest game changers for this decision is ultrasound at the bedside. What we're looking for is something called cardiac standstill. It's a surreal thing to see. The monitor might still show those weak electrical sparks of the agonal rhythm, but you put the ultrasound probe on the chest and the heart is perfectly still. No movement at all.
And the meaning of that finding is incredibly stark. If you have an agonal rhythm on the ECG and you see cardiac standstill on the ultrasound, the chance of survival is basically zero. This isn't a guess. It's objective data that helps the team make that unbelievably difficult decision to stop. And this really brings us right back to where we started, to that paradox. Seeing an agonal rhythm on the screen, that's a sign of a terrible prognosis. But if that same person is showing agonal breathing, if they're still taking those gasps while we're doing CPR, that's actually a good sign. It tells us the brain is still getting some blood and that maybe, just maybe, we should keep fighting.
When you step back, this entire topic really boils down to one very profound question. By learning to read these final signals from the heart, by knowing when to fight with everything we've got and when to respectfully stand down, how do we, in medicine, honor both the desperate struggle for life and the quiet certainty of death?